This video has been developed to present the continuous nerve block techniques and their indications for both the upper and lower extremity in orthopedic surgery using the ProLong needle. The patient is placed in the supine position with the head slightly turned to the opposite side of the block. The shoulder pushed downward and the elbow at a 90-degree angle with the hand placed on the chest. To better identify the lateral border of the sternocleidomastoid muscle, the patient is asked to raise his head. The interscaling groove between the anterior and middle scaling muscles is identified and marked by rolling the fingers posterior and lateral to the sternocleidomastoid muscle. Next, a horizontal line is drawn at the level of the cricoid cartilage. The intersection of these two lines represents the site of the introduction of the needle. Next, a local anesthetic of the skin with 1 to 2 cc's of 1% lidocaine is performed by introducing the needle subcutaneously. After appropriate disinfection of the skin and placement of sterile sheets, a 18-gauge needle is introduced to do a pre-hole before introducing a 40mm ProLong insulated 2E needle with the bevel oriented to the axilla. The needle connected to a nerve stimulator set up to deliver 1 to 1.5 milliamps is introduced in a caudal and posterior direction between the interscaling groove. The brachial plexus is very superficial at this point and can be damaged easily. Within 1 to 2 centimeters, a contraction of the deltoid, biceps, forearm, and hand is elicited that indicates the stimulation of the anterior trunk of the brachial plexus. The position of the needle is adjusted to maintain the motor response with a current between 0.5 and 0.3 milliamps. After negative aspiration for blood, 30 to 40 cc's of local anesthetics is slowly injected 5 cc's at a time with aspiration in between. Then the catheter is introduced between 3 to 5 centimeters beyond the tip of the needle and the introducer needle is pulled. To secure the catheter, it is tunneled under the skin. Some local anesthetic is injected subcutaneously, followed by the placement of an 18-gauge intravenous catheter. The needle to guide is removed and then the catheter is tunneled. Steri strips and tegaderm are placed to secure the catheter. The vertical technique. The patient is placed in a supine position. A line is drawn between the anterior acromial process of the scapula and the jugular fossa, with the shoulder pushed downward and the arm across the body. The midpoint of this line immediately below the clavicle is the site of the introduction of the needle. Next, a 50mm insulated 2E needle connected to a nerve stimulator is introduced vertically. Within 3 to 4 centimeters, a stimulation of the brachial plexus is produced. The local anesthetic mixture is injected and the catheter inserted and secured with steri strips and tegaderm. The patient is placed in supine position with the arm abducted and the forearm flexed. The axillary artery is marked. Next, a 50 mm prolonged needle connected to a nerve stimulator is introduced above the axillary artery at a 45-degree angle along the deltoid and biceps groove in search of the stimulation of the median nerve. A musculocutaneous response is elicited, indicating that the needle is too deep and outside of the brachial plexus sheath. The needle is withdrawn, and this results in a stimulation of the median nerve response as indicated by the flexion of the first 3 fingers. The local anesthetic mixture is injected, and the catheter is then introduced. We use the push and pull technique to remove the needle, and the dilation of the brachial plexus sheath confirms that the needle was in the right position, and then secure the catheter with steri strips.